to Baltimore, for those of you who are coming from out of town, and to the University of Maryland School of Law. It's a pleasure to see such a wonderful group of friends and colleagues and alums and experts here on the subject of today's roundtable, which is healthcare reform, the state of the states. I don't think I need to really say this because everyone in the room knows it, but in 2010, Congress passed and President Obama signed the Patient Protection and Affordable Care Act with the primary purpose of increasing the number of Americans who will have health insurance. And at that time, there was an estimated 49.9 million people in the country without health insurance. The success of the law, in part at least, will depend in part on the actions of the states, specifically their implementation of the health insurance exchanges and their decision on whether or not to expand Medicaid. And those are the two issues that are the focus of our roundtable today. We chose to have this roundtable as at least in significant part as a result of the work of my colleague Ellen Weber, who is also on our faculty and who's heavily involved in the healthcare reform work in Maryland, especially in the area of healthcare for individuals with substance abuse and mental health disorders. In 2011, Ellen was awarded a grant from the Open Society Institute to support a project called Advancing Access to Addiction Treatment, which was created to support research, education, and advocacy efforts to ensure expanded access to addiction treatment services in Maryland in the federal healthcare reform legislation as it's implemented. Ellen also put together and spoke at a panel last June that the American Society of Law, Medicine, and Ethics put together a conference for health law professors, and several of our participants today also spoke at that conference, including Bree Clark from Loyola Law School, John Jacoby from Seton Hall, Sally Sanford from the University of Washington School of Law, Sydney Watson from St. Louis University School of Law, and Elizabeth Weeks-Leonard from University of Georgia School of Law. That panel, in which the presenters talked about what was going on in their various states in terms of implementation of the Affordable Care Act, was so interesting and informative that we thought the topic could be the basis of another forum, larger gathering that would include individuals from additional states and at the federal level, so that people would have an opportunity to share and learn from each other about what they and their states are doing. So we are thrilled to have, as I said, such an informed and knowledgeable group of individuals sitting around the table today. A list of all of them is in your packets, and we also welcome our observers who may wish to ask questions or add to the discussion. Our hope is that we will learn from one another and perhaps share or come up with ideas that may benefit some states or advocates for healthcare reform as they try to move forward and increase the number of insured individuals in their state. Today's roundtable will be recorded and will be made available on our website so that individuals who are interested in the topic but were unable to attend can listen to what was discussed today. In addition, our Journal of Healthcare Law and Policy will be publishing a symposium issue on this topic that I know a number of you around the table will be contributing to. Today's roundtable would not have been possible without the help of a number of individuals. They include Virginia Rothorn, who's the managing director of our health law program and who has been communicating with many of you. And she and our coordinator, Adrian Harps, took care of all the details associated with planning this event. So I want to thank Virginia. I also want to thank the donors of the Reuben Schilling Mental Health Law Fund, which provided funding for today's roundtable, and third-year law student Rebecca Hall, who is the editor of the Journal of Healthcare Law and Policy, which will, as I said, be publishing papers developed from this conference. And, so our agenda today is in your packet, and as you can see, we'll be starting off with two speakers, remarks by Dr. Joshua Sharfstein, the Secretary of Maryland's Department of Health and Mental Hygiene. What did I say?
Oh, and grandson of Reuben Schilling.
Oh, and grandson of Reuben Schilling, yes. And also Sonia Schwartz of the National Academy for State Health Policy. After that, the day is divided into two parts. Part one will focus on implementation of health insurance exchanges at the federal level, and at the state level, and part 2 will focus on Medicaid expansion and decisions that the states are making about how to expand or whether to expand their Medicaid programs. There are 3 panels for each topic and 2 or 3 discussion leaders on each panel. The discussion leaders will speak for, we ask them to speak about 7 or 8 minutes on one aspect of the panel topic, and then open up discussion to everyone sitting around the table. In some cases, they may also throw out some questions about issues that they would like to get your input on. In others, they'll simply ask for comments on the issue. And you as members of the roundtable should be free to jump in during that point and offer your thoughts about the issue or ask questions of other panelists if you have them. For the lunch break, we have box lunches which will be served in the hall right outside this room. You're welcome to eat in the room, but also to walk around the law school. There's a coffee bar and place to sit, and there's outside seating. I don't know if some of you know that we are located, we are on a space next to the cemetery where Edgar Allan Poe was buried. So if you want to take a walk outside, you could look at that. The restrooms, I think most of you have found them, that are right across the hall. So that's it for housekeeping. So now I'd like to introduce our first speaker, Dr. Josh Sharfstein. He's a physician and the current secretary of the Maryland Department of Health and Mental Hygiene. He's also served as the principal deputy commissioner of the U.S. Food and Drug Administration, and before that, the health commissioner of the city of Baltimore. He's a native of the great state of Maryland and graduated from Harvard College in 1991 and then entered Harvard Medical School with a specialty in pediatrics. He left Boston for Washington, D.C., where he joined the Democratic staff of the House Government Reform Committee and served as health policy advisor to Congressman Henry Waxman. His early work in politics included work for Public Citizens Health Watch, and he's continued to be a leader in the area of public health and public health initiatives. He's been secretary of our State Department of Health and Mental Hygiene since 2011. And he will introduce our plenary speaker this morning, and then after she speaks, respond to some of her comments and share some of his own thoughts on concerns and practical concerns about implementation of the Affordable Care Act by the states.
Great, thank you very much, Diane, and thanks to the law school for putting this on. I appreciate the introduction. For this purpose, I'm also the chair of the Exchange Board in Maryland, so we have a lot of different perspectives. Just very briefly, I would say that states are facing a lot of different challenges at the moment. Some of them are facing some pretty unusual political challenges. Talking to people in different states about all the different things that are coming up. Maryland, we're not so much facing those kinds of political challenges where people are trying to block implementation of different parts of this. But I think, I'm sure Sonia will talk a little bit about some of those challenges that exist around the country. At some of the events I've gone to, people get up and say, here's what we're doing to implement the Affordable Care Act, and they just sit down. You know, I mean, that actually happened at a national conference I was at in Baltimore. The second thing is that there are these broad policy issues, and I think there's some really important policy calls for states, such as expanding Medicaid or not. And I think that one of the ironies of the Supreme Court decision, I think, is that there's been a lot of focus on Medicaid, and a lot of, people don't want to back off funding Medicaid because of the importance of states deciding to do it, which has been actually worked out pretty well. But I think that in Maryland, we've had the ability through a lot of planning and the fact that we were out pretty early wanting to do it, to have a big public discussion around the policy decisions and be able to make, I think, almost all the big policy decisions without a tremendous amount of, unhappiness at the end of the day. There was some vigorous discussion, but people really came around. But I think that you're going to hear that in addition to politics, there are some policy issues that are still playing out, and I think it's harder for states that get a late start to really be able to resolve those. The third is the implementation side of things, and I'll just give you, 3 specific areas. One, is IT, which is just such a tremendous challenge. When I was at FDA, I spent a lot of time scaling back or ending IT projects that had really gone awry, and I think that the problem, the IT challenge here has to do not just with setting up the exchange and how you pick your plans, but the whole eligibility system, new eligibility rules for Medicaid, interactions with legacy systems. It is an enormously complex project, which creates a lot of challenges. The second area, I think, particularly for this group perhaps, is the issues of, I found that from a lot of different, everybody is so excited, and the Affordable Care Act is such a step forward for health, that people want to solve the issue that they've been working on for a very long time right away. And I care deeply about a lot of different public health issues as the health commissioner in the city for a while, and but I acutely see the trade-off between trying to solve everything right now and actually getting the lights to turn on. And in addition, there's the broad policy issues that have to be made, and then there are a lot of things where we're coming down, even in Maryland, as that's something we can't tackle the first year, period. We're going to see how it goes, and then we will circle back if we need to. And I think that's a perhaps a theme, but there's a lot of different. If you were walking around with me, you'd see many different people from different political positions, everything, that want their issue to be solved right away. They've waited for it. Here it is. We're going to do it, but it is just not really possible. The third part of implementation I just mentioned, and maybe Sonia could comment on this a little, is that I've been impressed that there are multiple areas of implementation. That it is not just the state IT project. It is what the federal government's going to be able to deliver for data. It is there's an entire relationship between the federal government and insurers that's outside of what states are responsible for and how they handle the advanceable tax credits. There are like several different dimensions that all have to come together for this to be successful. It is not just a project with one leader at the state that it all kind of comes together. So that adds an enormous amount of complexity to it. So, I think that Sonia and the work that she does and the organizations that she works with are very important to keep track of how this is going in different states. And I think that what you'll probably hear is that there are likely going to be some bumps in the implementation, and I think everybody understands that at a conceptual level. I think I may have a better understanding, as I'm seeing the bumps. I feel like we're like in the car and the potholes are out there, and maybe as she talks, she can talk a little bit about how she sees those bumps playing out, and what kind, how it's really important for people to be prepared, that it may be their issue where there's a bump on, and that we're going to have to work through them, and it may take a little bit of time for the smooth sailing that we all hope to have to maybe I should have said waves instead of bumps, and then I could have gone to smooth sailing, but for that to play out. So I would just say finally that there are some really great efforts, including with NASPE and the state forums to bring states together. There's a lot of interchange between and discussion between states. Some of us there are sort of like teams of states using the same IT vendors, and there's a lot of discussion among the states there. And I think it's been a really helpful role. So, Sonia?
Thanks. Let me just get technology squared away. I don't know, is this on or do we need it? We may not need it, but sure.
So folks sitting over here, you might want
This
to
will only take a second. Yes, sir. You may not need it, but it doesn't hurt. Well, before the mic goes on, I'll just say that it's really nice to be here and have Dr. Sharfstein start out. At the National Academy for State Health Policy, where I work, We don't just really follow the state policies in terms of implementation, we also follow the people behind the policies. And it's really a community of people around the country. And Dr. Sharfstein is one of the leaders of all of that. And I followed him even when he was at the city level, even though, you know, for work purposes, I'm only supposed to look at states. And he's just been doing phenomenal work, incredible amount of passion and dedication to all the issues we're going to be talking about today. So let's see if the mic is on. And my job this morning is to just kind of awaken you and get you ready for the discussions that'll happen later today. So I'm going to give you kind of like a tour organized around 10 themes that are practical considerations for states as they implement the Affordable Care Act. And bear with my Prezi. We'll see how it goes. First theme. This is really now, finally, prime time for states implementing the health reform law. And we'll just spend a minute going back through time a little bit. It'll be 3 years in March from when the president signed the Affordable Care Act. And I don't know if you're like me, but I try not to be naive, but I really did not expect implementation to stall out for so long after the law was signed. I knew there might be legal challenges. I knew that the opposition would not disappear, but the amount of time that passed from when it was signed to now, finally, where action is really getting going across the country, was a shock, I think, for a lot of us. You remember last summer, if you were like me, we have a lot of law professors in the room. Maybe you took a little time to hang out on SCOTUS blog with the other millions of people. We were all there, losing our appetite every morning, waiting to see if there'd be a decision. And we finally got one. I would say the decision was a surprise. I don't think we expected it to go and be all about Medicaid, but it was. And hi, Jennifer. We'll talk more about Medicaid in a minute, but that was an unexpected outcome. We then had to wait, and I work on a website called statereform.org where we track states' progress on implementation, and we're always thinking, after the Supreme Court, it's going to get better. After the elections, it's going to get better. And finally, after the elections, things really have picked up. I mean, even just traffic to our website, we get a couple thousand hits a week, and now we're getting 4,000 and 5,000 hits a week. I mean, states are just really paying attention now. And, I don't know if you're like me, but we thought, with Obama's lackluster performance in the first debate and the economy where it was, we weren't sure if, the ACA's major advocate was going to stay in office, and we thought maybe in Congress we'd have some rollback as well. And, we made it through that obstacle too. And so we're really now looking at the future. And these are some of the key exchange deadlines. I'll talk in a minute about the exchanges. The sort of open enrollment, the exchanges are pretty much set for the models they're going to have when open enrollment hits in the fall. And some of the big deadlines and things to look for in the spring are going to be at the state level and at the federal level, plan certification is going to start happening, and we'll know more by summer, but we'll really see a little bit more about what these plans look like, and more details will arise. And then I'll talk in a minute about how long we are till some of the big sweaty deadlines for states. What I wanted to say, though, is that at Nashby, where I work, we see some of the folks who were most sort of positive and dedicated to January 1st, 2014, even after the law passed. The law passed in March, and we had our annual conference in October. And already we had these very earnest state officials coming to the conference with buttons that said 2014 is today. They were living it 3 years ago, and they were doing whatever they could to get their states ready at that time. So there were some people that all along have been pointing toward 2014. Just a reminder that open enrollment starts October 1st. How many state officials are here? We've got Dr. Sharfstein. I don't want to make them sweat or cry, but that's not really very long. It's about 7 months away. And then coverage starts in 306 days. And, in Oregon, they had a ticker on their website from like March 23rd, 2010 on. And, that state has not really moved from its position of full implementation. And it's a good reminder of how few days remain. Okay. We're going to look a little bit at governance, and I mean, you might call this politics, but it's also an issue of kind of authority of different agents in state government to make decisions about health reform. There are a lot of decisions that have to be made. Some of them involve budget, some of them don't. There are a lot of new governance models coming out of it, and I just wanted to tell you a couple stories about this. First, I'll take you to Mississippi. where Governor Bryant, not a huge supporter of the Affordable Care Act, not a big proponent of doing a state-based health insurance exchange, was poised to not really, not go forward with that. And then came the insurance commissioner, Cheney, who's also a Republican, also elected, not appointed by the governor, who thought, you know what, I think it's in the best interest of Mississippi to do its own exchange. It's going to be a free market exchange. It won't be a big government exchange, but I think we should do it. I don't think we should let the feds mess around with our people's health insurance. And the governor did not agree. The attorney general is actually a Democrat, then was left to do sort of a legal opinion about who had jurisdiction and who had authority to make this decision. And the Attorney General sided with the insurance commissioner and said, under admin law and other rules in Mississippi, I think the insurance commissioner can go ahead with his state exchange. And it took until there was a letter of intent that the insurance commissioner wrote to HHS, and this is Gary Cohen at CSIO, which is the agency at the federal level that kind of oversees the exchanges, said, actually, folks, this is all lovely. You said this letter of intent, but we need the governor to endorse and approve a state exchange. We can't go forward with this letter from the insurance commissioner. So that ended that, and now in Mississippi, they'll have a federally facilitated exchange. Another place to look for interesting governance dynamics is the Medicaid expansion debate. You may have seen news today from Arkansas. It's kind of an ongoing we'll have to see what happens, but the governor there has all along been pretty sure he wants to do the Medicaid expansion. His legislature, he's a Democrat. The legislature is Republican dominated and actually blocked efforts in Arkansas to do a state health insurance exchange. And so, there is a concern that they will go along to support the Medicaid expansion as well. And the governor is now meeting with HHS, I think, in the next day or two to discuss different ways to approach the Medicaid expansion. And we'll talk a little bit more about that on another slide in a minute. But in Missouri, we have a similar situation. We have a Democratic governor supporting the expansion. We have a pretty conservative Republican legislature that actually tried to make it a criminal offense for federal officials to implement and enforce the Affordable Care Act in the state. That didn't pass, but it was definitely proposed. And so we may see some interesting debates playing out there. What's also interesting, and I'm sure you guys, there's not really a day goes by where there isn't a news story about a governor and the Medicaid expansion, but these end states, the new states, Nevada, New Jersey, New Mexico, all have Republican governors and Democratic legislatures. And since the governor supports expansion, I think we can be pretty sure that we've got green flags there for kind of smooth sailing with the expansion. And then Virginia, we have Joe here, and hopefully later he works for the Virginia legislature. He'll tell us a little bit more about what's happening there, but it seems the most recent update is that the governor is sort of supporting the expansion, not sure, and the legislature, even though, there are some there's a strong Republican theme in the legislature. It seems like the legislators are more supportive, actually, or more comfortable than the governor, but they have certain limits they want to place on the expansion. Okay. Moving to another theme, we've heard if you're able to participate in any of these regular calls that happen between the states and feds about health reform implementation, you'll know that there's quite a dance going on around wanting affirmation that certain policies are what they are so that states can move, but also only wanting that if the outcome is one that states like. So when the states like the direction that the feds are going, they want to see regulations right away. And when they don't like it, they're nervous about having anything, more firmly planted. So the love story is an odd one, and it's about essential health benefits regulations, believe it or not. In the Affordable Care Act, you may remember, there was an element that would have required states to actually defray some of the costs of mandated benefits that existed in states that went beyond the 10 essential health benefits. You may remember there were 10 essential health benefits laid out in the Affordable Care Act, and some of them were already commonplace in most private market plans, but some of them were a little, potentially a little transformative, relating to habilitative care, mental health care, certain kinds of preventive care. And then on the other hand, states over the years had passed a lot of laws that pertain to their commercial market that provided certain kinds of special mandated benefits, potentially for autism, potentially for acupuncture, potentially for IVF, all sorts of things. And the concern was that they would have to pay back the money spent by plans because of the federal subsidies going in, to defray the cost of those additional benefits. So the guidance that came out a little over a year ago was quite a surprise, and I think good news to a lot of states, but they didn't quite want to hear it. They didn't quite want to embrace that it was really true. It basically said that they would no longer have to, at least sort of provided a safe harbor for states to not have to defray the cost of those mandated benefits in the first couple years, as long as they chose a benchmark plan that included those mandated benefits. So mostly, if they chose a small group plan in the state that already had those benefits in it, they were home free. When this guidance came out, all the calls between states and feds basically went like this, like, you sure we don't have to pay it? We really don't have to pay it? If we do this, do we have to pay it? If we do that, do we have to pay it? Just such concern that this wasn't going to last, or this was too good to be true. And honestly, when the proposed reg came out, they said, we need a final reg. And now that the final reg's out, I think we're finally in a place where states, at least for till 2016, feel like pretty comfortable with this element. A not so happy story for some states is on the partial Medicaid expansion. So when you probably are aware of this, when the Supreme Court's decision came out, I think a lot of us in Washington thought it took us a couple days to get our heads around this whole Medicaid change. But honestly, at the state level, particularly states with Republican governors, within 10 seconds, they'd already figured out that it would behoove them to potentially do a partial Medicaid expansion, going up only to about 100% of poverty, and then to see if they could instead have those from 100% of poverty and up, or really 101 and up, paid for through the subsidies in the exchange. Because in the exchange, states have no financial, especially if it's a federal exchange, there's no financial pressure on the state to do anything. And with Medicaid over the years, you know, there are some financial costs for the states. And so the begging and pleading and questioning kind of started of the feds, you know, how are they gonna, it's interesting, you know, you take this law and you make this change at the Supreme Court level, but the law has been left the same. And so, you know, we had to see how HHS would interpret this. States said, you know, we need flexibility, let us do this partial expansion. And so far, basically what Secretary Sebelius has said is that if you want the high match rate, the enhanced match of 100%, which is obviously very desirable, you got to go all the way to 138% of poverty. You can't mess around with partial expansions, but you know, this story isn't really over yet. And we saw today in the news, we've been hearing that Arkansas is looking at potentially some waiver options, potentially vouchers for people over 100 to buy into the exchange, or maybe instead making it optional whether people go into the exchange or Medicaid. And what HHS has said is states, sure, apply for waivers, come talk to us about waivers, but you're not going to get this pretty match rate for these waivers. So, but we may see a change. We'll have to see how successful the governor of Arkansas is this week with the secretary. So this is something to watch, and I think it'll be interesting to see how it plays out. Next. The Medicaid expansion decision gets all the attention, but there actually are a ton of practical issues, and Dr. Sharfstein touched on this. I'm going to walk through a couple that states have to deal with in Medicaid, whether or not they expand. That Medicaid agency, if it wants to get in shape for 2014, has got to be moving on some of these things. And I'll just go through them at a high level. So here's the expansion decision on the left, and here's all the operational and other related things that the Medicaid agency has to worry about. In terms of the expansion, sorry about that. In terms of the expansion, we're now at a place where we're tracking this too, but this is the advisory board's graphic because it's a little simpler. We've got kind of a majority of states leaning toward participating, and then we're either unsure or we've got a little less than half leaning the other direction. But when it comes to actually making Medicaid work, regardless of the expansion, there's just a ton states need to do, and I'll just walk through these briefly at a high level. Related to eligibility and enrollment, states have to maintain coverage of adults and children at certain poverty levels. They have to expand coverage to kids leaving foster care. They have to move CHIP kids into Medicaid and keep the financing enhanced for CHIP. And they have to think about the modified adjusted gross income rules for counting eligibility. Those of you in the room who've worked on poverty programs, welfare law, know how complicated entitlements are and how the income methodology is so vital to, figuring out who's eligible, and it comes with certain rights attached to it. And the switch to Magi is made more complicated by the fact that states have to keep eligibility processes and determinations the way they are now for certain people as well. So there's a lot there, and I'm sure there are people in the room more expert in this than me today that will probably talk a lot more about this. In terms of operations, as Dr. Sharfstein said, IT systems have to be upgraded, information has to be safeguarded, because a lot of information is going to be changing hands from the feds to states and throughout programs, and they have to get an increase in primary care reimbursement rates in Medicaid of 100% Medicare rates up and running very quickly. I mentioned before that some CHIP kids are moving into Medicaid, and states have to be able to draw down the enhanced match for CHIP, which is higher than Medicaid for those, and then they want to be claiming enhanced funding for the new eligibles, the expansion, but they can't claim that for others, so they have to understand kind of who's who in order to draw down the right amount of federal money and maximize the match they can get, and that's very complicated. And states have been disappointed all over the map, really frustrated and disappointed with the feds for not clarifying these rules sooner, and feeling like states have to kind of invent the policy and then kind of check it and refine it again once the regs came out. In terms of benefit design, in the commercial market, states had to choose benchmark plans. In Medicaid, for the expansion population, states are supposed to choose benchmark plans. They're a little different than the commercial ones. And it's complicated by the fact that states actually could keep benefits the same if the secretary approves that. And some of us feel like with everything that's going on at the state level now with Medicaid, maybe just keeping the plans the way they are and getting approval might make the most sense and save time and energy and be less costly in some ways. But a lot of states are going to be slimming down the Medicaid package and choosing a benchmark, I think. And then they have to come into compliance with EHB as well, and all the coverage standards that come with that. Last, there's just a huge emphasis on consumer assistance in the Affordable Care Act. And, a lot of states we work with at NASHB, we have this huge maximizing enrollment project. We've been working with 7 states to improve enrollment and the processes and the whole system. But there's a huge emphasis on consumers being able to enroll any way they want. They have to be able to enroll online. They have to be able to call in. They have to be able to walk in. Every language needs to be addressed. People with disabilities need extra help, and it needs to be super accessible. And I think the hardest part, there are a lot of hard parts, but the hardest one is at this time, really only one state has a real point-in-time automatic eligibility system, and that's Oklahoma. And other states are somewhere in the process of getting there, but some pretty far away still. So there's a lot that happens there, and there are a lot of differences. If you're a Medicaid expansion state, but you have an FFE, there are issues. If you're not expanding Medicaid and you have a state exchange, I'm trying to think if there are any, we could look. There are other issues, and so there's just a lot of complications around that. So that's a Medicaid issue. This one is for Kevin Lucha in the audience. I have his slides here. He and his colleagues at Georgetown have been doing a lot of work to monitor some of the commercial market reforms in the Affordable Care Act. And for most states in the country, this is actually, I think, the biggest leap forward, or the biggest set of changes. And Brian Webb is here as well from the NEIC, so he knows about this. States are really far behind on this. And it's complicated by the fact that some states think that they already have the authority to enforce the law, and it's unclear whether they really do. So these are the big 7. There were a bunch of consumer protections that already had to have taken effect, like no pre-existing condition for kids, covering dependents up to age 26 on their parents' plans. There was a whole bunch that already took effect. But these are the biggies in my mind. These are the ones that are pretty fundamental changes to the way that insurance is sold in America and people buy it. And they apply to the whole market, not just the exchange, but the exchange kind of offers like a second look or a second chance to kind of look at these policies more carefully and make sure, and scrutinize and make sure they're following all these rules. So guarantee issue, is a huge change. In most states before the Affordable Care Act, people were not guaranteed an offer of insurance if they had a pre-existing condition or any kind of health illness, or they were too old or whatever. They could be denied. Waiting periods will be no longer. longer. There are certain rating limitations. States can't vary anymore by health status. I mean, insurers can't vary at all by health status. They can vary by age, they can vary by geography, but there are real limits on that states need to put into effect and get insurance companies to comply with. No more pre-X's. Obviously, the EHB we talked about, limits on out-of-pocket costs, and then this notion of actuarial value and plans at certain levels of actuarial value, which is new, to kind of try to standardize some of the plans. This is Georgetown's work again. They did this paper for the Commonwealth Fund that you can find on the Commonwealth website, and really they found, and don't worry Maryland, you're very close, but in Connecticut, they found Connecticut was the only state that had done all 7 of the things I just showed you at the time they did the survey, which is not long ago. And then about 11 more states are on their way. They've done some of the things. And Maryland, I understand, has done basically all the things. I think the one thing that remained, which I'm curious about, and maybe Kevin will tell us later, is that it looked like they hadn't taken care of guarantee issue yet. I don't know. I know there's a history with a high-risk pool here, so maybe there's more to it than that. Maybe they're really done. And then in California, they've done most of what they need to do, but they haven't put in the cost-sharing protections yet. Okay. This is just a little note about, oh yeah, go ahead, tell. Do you want to tell about the guarantee issue?
No, well, there is going to be another bill this year.
Okay.
In the Maryland legislature, I think, just to kind of tie it all up. There was one last year that the insurance administration did.
Cool, cool, cool. I figured you're like this, yeah, you're very close. I didn't want to, make anyone feel bad.
Just in terms of time,
yeah.
To keep on schedule, I think, like.
5 more minutes?
Yeah, maybe 5 to 7.
Okay, that's good. Just a quick note that, there is in the ACA the authority for the feds to come in and enforce if states don't, but practically speaking, really hard for feds to do that. They don't have the history of doing it. It's just practically, with all the states in the country, really, really tough. Okay, let's keep moving. So one note is just that state-based exchanges, everyone's talking about who's falling into what model. Important to remember that people can still use premium subsidies and actually get insurance no matter whether it's a state or federal exchange. Sometimes I think people even just lose that point. But really, I'm going to zip through here. This is sort of where we are. This is pretty clear now that when open enrollment starts, these are the exchange models we'll have. 17 states in DC are state-based, a handful, around 7 are partnership, and the majority of the country is FFE. Here's a look at who's the partnership. Everyone doing a partnership is really going to do plan management, and most are going to do consumer assistance too, but I was just doing plan management. I'm not going to go into this right now. We just don't have time. What I wanted to say was just that the main, I think, asset of doing a state exchange, and this is my boss's new blog that I wanted to show you all, but it's just that those of you who know Alan can smile. The real reason to do it is if your state has a really pressing and important vision about state health policy, having a state exchange is another opportunity to align another kind of purchasing mechanism, another avenue of coverage with your vision. And so, at NASHB we work with all states, and my particular vision may look a little more like Maryland's, but Utah has a vision. They want to provide small businesses with more variety of products, more choice, potentially lower cost, potentially slightly higher deductible policies, and they're doing it, and they're trying to get HHS to go along with them and say that they can be a state exchange doing some of these things for small business, and this is their website. And in Oregon, they're coordinating care any way they can. They're using every possible lever, and this is just a little picture, but they're going to be using their exchange to just become part of that whole vision in Oregon, a really different one than Utah. Couple more things. This is something people don't talk about a lot, but my staff and I, this is something we really appreciate and find really interesting, and I think for researchers is really helpful, which is that some of the state-based insurance exchanges are really open. You can really get in there, even if you can't be part of it, and find out what's going on and learn about upcoming important decisions, past decisions. And a lot of this is happening outside of the legislative realm. It's happening in meetings. It's happening among boards. And there are a couple different models for exchanges. The model that seems to be the most open is the model Maryland has, which is quasi-governmental. It's when you have a board, it's usually made up partly of private citizen stakeholder types and some government officials, and you staff it, and every meeting is under the State Sunshine Act. everything's public, everything's open. A lot of these important policy decisions are made with testimony and people listening, and it makes a difference. Just quickly, in California, you can practically find out like what they're wearing today on their website. They post everything, and for real policy wonks, like some of the folks in my office will watch their board meetings webcast, and here's just a picture from this week. Because of the size of the state, they're webcasting everything. So, if you want to, you can learn as much as you want about what they're doing. In Maryland as well, they've got a really friendly website. They tell you about all the meetings coming up and ways to participate. And so, there's really a lot. And in terms of what researchers may need to look at policies and practices, there's a lot posted that you can use to analyze if you're interested in it. Okay, I'm going to try to wrap pretty soon. Just an important note that in most of the country, including in Maryland, exchanges are not going to start out as active purchasers. I think some wish they were, some are glad they're not, but this could certainly change. Just a quick note, there are different ways to be active purchasers. States that are doing this right now are doing it in two different ways in their exchange. One is just to kind of go beyond, there's sort of some federal certification requirements, but states can go beyond those and just add more requirements and then take all comers based on who meets those requirements. Or states can instead either have more requirements and then limit the number of plans they choose, or they can even go a step further and selectively contract and negotiate prices with plans. And only a handful of states are going to be doing that in the first year or two. Of the states that are expressly allowed, there are, let's see, 7 or 8. Maryland is allowed, but in the first year or two of their exchange, they're not really going to go this route. I think this is a little bit of what Dr. Sharfstein was saying, which is mission critical path to open enrollment, critical path to 2014, and then adding in some refinements and other important policy strategies later. And so a lot of states, even if they have the authority, aren't going to be able to get this up and running right away. However, there are California, Connecticut, DC, Rhode Island, Vermont, Oregon do have RFPs out. They do have more stringent requirements than federal, and some of them do plan to selectively contract and even to negotiate price. So we'll get to see a little of that in the first year. FFE, when it starts out, is an open marketplace exchange. They have some federal standards that are all in law and regulation, and plans that meet those can offer in the exchange. But they, obviously they have to check against all the rules and make sure that they meet those rules. And then there are lots of quality levers we don't have time to go into, but if states want to use the exchange as a way to enhance quality, they can. This is going to be a quickie. It's not just about how many people enroll, it's about who enrolls. And so if states just sit back, particularly if they have a state exchange, and they just sit back and do nothing, I think there's a concern that only people who need coverage now, who are facing pressing issues, are going to show up. So states have realized this, and California is really the champion of that. Their exchange director, they are pulling out all the stops to plan incredibly creative and intense outreach efforts. I was looking at California's plan. It's 142 pages, and they're doing everything. But the issue is really going to be cost. It's tough when you look at this calculator that Kaiser Family Foundation has, and you put in 25-year-old guy, this is based on someone in my office, 25-year-old guy, $35,000 a year income, right out of college. Luckily he has employer coverage, but if he didn't, he only gets a $66 subsidy for the year. His coverage, the premium is $3,391, and with the subsidy, it's $3,325. Making $35,000 a year, maybe he can afford it. He's going to have to pay a penalty if he doesn't, but it's tight, I'd say. And then if you look at a family of 4 at $50,000 a year, probably around 250% of poverty, their subsidy is much bigger. They get almost a $9,000 federal subsidy, but they still have to pay $3,000, almost $400 a year for coverage, and at $50,000 of income, that's tough. They'll have to make it a priority. So the cost is going to be the first indicator of, whether people can really enroll. But after that, clearly, we got to get out there and tell people about these new programs. When Rural America did surveys, this is a huge national campaign, public and private sector, to get people covered. They found that, it's not surprising that 80% of people who might be eligible for Medicaid didn't know they might be, but also more than 80% of people that might be eligible for a subsidy didn't know. So there's a lot of work that needs to happen. States are rolling out the welcome mat in different ways. this is the message I wanted to leave you with, which is that, you know, it's not going to be perfect January 1st, 2014. States are doing what they can to make it mission critical, do what they can. There will be exchanges running, there will be eligibility systems running, but they're not going to be perfect. The data is not going to be running as smooth. The call centers may not be completely adequate. There are going to be some warts. And I think everyone in the room has a chance to do something to help. Those of you who are law professors, gather ideas from other states to help solve problems in your state. You know, there may be an emerging problem that someone's already figured out kind of how to solve that you can adapt. If you have a state exchange in your state, get involved, participate in that, provide input into decisions happening now and in the future. In an FFE state, it's hard because you don't really have a lot of folks to kind of coalesce around, but there's a huge role in regulating insurance there that states still have, and there's still a huge consumer assistance role. These folks are residents of your state. They're going to call their legislator. They're going to call their insurance commissioner, and so those people need to be prepared. Obviously, you touch a lot of students. Educate them about the law and what it really means. You have access to media sometimes, colleagues. Just, you know, tell people who to hold accountable. Talk about what the real problems are and how to solve them. And last, you know, there hasn't been a lot of time to write about a lot of these problems yet. I was asked to maybe write an article today, and I honestly feel like until 2014, those of us who do the kind of work I do are better off kind of helping solve problems than doing a lot of writing. But when you have a chance to do some writing, talk about what issues are emerging, what are some of the solutions, what's working, what's not working, and try to help fix some of these problems. They're going to need to be state-level regulatory and legal fixes. They're going to need to be federal fixes, and we need your help. And these are just the 10 things again. And, you know, if we start conversations today that we can't finish, you're welcome to have discussions and stuff on our site. So I'll see you there.
Questions for Sonia?
Questions?
I do have a question.
Yes.
Sonia, on the statistics, the numbers you gave in terms of what it would cost enrollees for the program, that was almost $4,000 fee. Did that include, was that just the actual, did it include co-pays and cost sharing as well?
I don't think so. I think the Kaiser calculator is just about premiums.
So it more than likely would be more than that?
Yep. Yep.
I was at a meeting recently where getting a lot of questions, and the first person said, I don't think anybody is going to sign up because the premium costs will be too high and the cost sharing costs will be too high. You just, no matter how much, you know, it's going to be very, very hard to get people to enroll. And the next person said, with all these people covered, you're not going to have enough primary care to take care of them. It's going to be a disaster. And I just thought, I said, well, the good news for me is you both can't be right.
And also, clearly that's not the actual cost in any one state or anyone, that's just a projection. So we don't really know.
Judy, I know you have a
I also
thought.
wanted to know, because I think there is a lot of angst when people use, the calculator is an amazing tool. But I think you have to remember, and in the part we'll be talking about this afternoon, that's the second lowest silver plan, and if there's a lot of competition, there may be cheaper plans available to people, and their contribution will go down. The subsidy stays constant, and that's what you shop with. So I think that's the other thing that's really important, because I think people see that number and just freak out, as you did, Roger.
One other thing to note is that, and we'll talk about this more with consumer access, but in trying to help people really think about what the premium means, there's been discussion of creating calculators that actually show people's out-of-pocket costs, so they know how to value the benefits of the plan, right? Because you raise a really important point about the premium based on other priorities that people have, but in terms of educating people about what their exposure is without it, kind of what kinds of things
Or what they're already paying for prescriptions out of pocket if they're uninsured, things like that.
Yeah, so that information about what you'd have to pay outside of that for each plan, but also if you don't have a plan, what medical care even costs. That's some of the information I know some websites are trying to make sure they can get out easily.
Can I just ask people the first time they say something to say where they're from? So their name and their, yeah. Go ahead.
I'm Sally Sanford from the University of Washington, and following up on those two, I have a question that I just sort of started to understand. This issue of the bronze trap, that people might be inclined to get a bronze plan, but then on the bronze plan you don't get cost-sharing support, and that consumers are not likely to, unless it's really in their face, understand that. And that can really make a difference in their total out-of-pocket. And that insurers are worried then that people will choose the bronze plan and not be able to afford out-of-pocket. Why is there this bronze trap? Does anybody know?
So I'm Judy Solomon from the Center on Budget and Policy Priorities. People below 250% of the poverty line, in addition to the support for premiums, they get subsidies for cost sharing that kind of buy them up a little bit. Between 200 250, it's really minimal. It's a 73% actuarial versus 70, but then it becomes a little bit more substantial. If you pick the bronze plan, which you can do, and probably if you took that subsidy, it would go much farther, but then you don't get the cost-sharing subsidies. They only apply to the silver level. So people would have a plan at a 60% actuarial value, which means on average across the population, it pays 60% of the cost of the covered benefits. And that means big deductible, very big deductible, high cost sharing. So I think a lot of people, providers in particular, are worried people are going to come in and they're not going to really have coverage in that first period. So that's the bronze trap, I think.
Yeah.
Patty Bruzang from Manat. I think that these issues speak a lot to the importance of the plan presentment function of the website, but also to this navigator and consumer assistance functionality, that this is complicated, and there are lots of studies that show that people underestimate their healthcare needs, when they're thinking about, how many doctor's visits will I have a year, that we tend to underestimate that. So that it's really important to have these supportive tools for consumers to help them really project out and not get the sticker shock on the premium because they're not looking at what their out-of-pocket cost is going to be sort of on utilization-based costs. I think that it seems like exchanges will be at one level on that plan presentment and consumer support in 2014, and I think we'll get better at it over time, that support will improve, but clearly it's going to be critical.
Well, there are two things: presenting the information in as good a way as possible, and then what people actually decide to do. And part of it is we're just looking to see what people decide to do. But I mean, the thing is, it's not totally stuck in time. You can then respond. There are different policies that could respond to problems that you identify or concerns that people have, or people can't afford it, then you have to think about other approaches. But there's some ideas out there. It's probably not going to be in the first year that you can roll everything out, but that's an example of something that may have to be adjusted. And that certainly, I get a lot of people coming with specific disease groups saying, I'm worried about this out-of-pocket that could hit people with disease X or disease Y or disease Z, and I can't say that's not going to happen. I mean, that's going to happen. We're going to have to see it. I want you to monitor it, and then maybe for year 2 or year 3, we'll have to think about how to address it.
This is Cheryl Fitzpatrick from Families USA. Besides getting people to think about their choices, there will be people in this sort of Hobson's choice about, I can only afford one or the other. Do I deal with premiums or do I deal with co-pays? And I think it's going to be important for safety net services as well as private charities to realign their programs to deal with underinsured people. When Part D went into effect, it was a while before prescription drug manufacturers realized that there would be people who are now insured for drugs but can't afford some co-pays. And so it's really important that we send that message that people need to realign their programs to help people who can't afford out-of-pocket costs.
Marty, you?
Hi, Marty Wasserman. I used to have Josh's position, and I don't envy you. But you talked about uncertainty, and I've sort of been following what's gone on in Maryland for the last 3 years and the difficulty and complexity of getting things through the Maryland legislature. And we are so far ahead of everybody else. And the questions I'm hearing are so granular that I'd just be interested in both yours and Sonia's interpretation of how can the states, what you said were the conflicts between the one house or the legislature in one party and no matter which, whether the governor's a Democrat or Republican, and if there's not bicameral agreement, you know, how can this thing ever come to pass in 300+ days?
There really are two different things. I think the Maryland legislature has actually been incredibly supportive. And I mean, we have a process, but it has worked incredibly well, and there's some just phenomenally good legislators to work with. And they've also been open to flexibility. I mean, we came in at the last minute last year and said we need to have an interim reg procedure or an interim policy procedure because we don't have time for the whole regulatory process. And that regulatory process goes through the legislature in Maryland, and they were willing to give us, you know, an exception where we're just telling them about things. So there are two questions, and I'll ask them to Sonia. One is other states, right? But then the second thing, I think, is underappreciated, that even in Maryland, the legislature only meets a few months a year. And so things have been coming out that like are off kilter with our legislature, like suddenly there's a new program available, or we just got this dental reg, which is very complicated and unanticipated in some respects, where the cost sharing doesn't apply to the standalone dental plans, and that may have legislative implications for us, and we've got to, like, you know, we're moving the bill through now, so it's like a all hands on deck to figure out the policy and what we're going to do. But then there may be things that come out after the legislature's met, and there were things before, and so it's both getting agreement and the timing issue is really, really tricky. There are already a number of things that we can't do this year in year one just because of the way that the timing is working.
Yeah, I mean, one thing that we see, and when I present with people from the National Conference of State Legislatures, they often remind me, is that most legislators, there are a lot of legislators in their first term, and they don't know the difference between Medicaid and Medicare. They say this, so I don't have to sound mean. And then on the other hand, you know, you have these executive branch agencies where, for the most part, there's a lot of expertise. There isn't always the will to do things at a higher level, but there's a lot of expertise, and so it's very hard to kind of get in sync with the legislature, which is operating kind of in a different place. But also, I mean, I'd say before the Supreme Court decision, this is how I characterize the country. I would say there was about a dozen states that were like ready for the big fight, just doing everything they could to coordinate and move forward and kick serious butt on the ACA. You know, obviously there were going to be problems, but they were there. And then there was a dozen that were kicking and screaming, you know, we're not going to do it, we're going to sue, we're going to fight it. And the rest of the country was kind of in between, kind of a little, maybe good on insurance, not focused on Medicaid, you know, a mishmash. And now I think we're going to see more like 20 states closer to Rocky climbing the steps training, but it's going to, they have to catch up. And so a lot of our work is to help kind of speed them up, help them find a law or a reg or policy that they can take from a state where they like the direction it's going, and, you know, as quickly as they can in the legislative session that they have, make it work for now. And so that's where we are. And then there are other states that are still going to fight and not do much. And feds may have to come in and enforce. We'll see. I mean, there are going to be major gaps in coverage because there won't be Medicaid for the lowest income. But honestly, the FFE is the FFE. People can get a premium. You know, they can get a tax credit to buy there, so it's something. And, you know, we're seeing more states moving toward the Medicaid expansion than we expected. So, you know, it's a patchwork, but I think we're going to be in better shape than some of us may have thought. So,
I think with that,
yeah,
we'll probably end the first session. I want to thank Sonia and Dr. Sharfstein for their comments. I can already tell we're going to have a lively discussion for the rest of the day. So I'm going to turn it over to my colleague Ellen Lover, and she's going to lead the next panel.
So thank you very much, and thanks for kicking all of that off, Dr. Sharfstein and Sonia. And so we're going to start focusing on some of the issues that Sonia has already raised with regard to the implementation of the insurance exchanges. Now that obviously encompasses not only the exchange market, but also the outside market. And so all of the conversations that we are going to have over the rest of the morning are going to focus on that. What we're going to talk about first is the implementation of the essential health benefits. And for that, we have three folks who are going to sort of lead off the discussion with some very brief remarks. First, Susan McNally, who is with the Office of Personnel Management. She is the Senior Advisor for Intergovernmental Affairs. She's going to share some information with us about multi-state plans. Then we will have Patricia Buzang, who is the Managing Director for Manat Health Solutions. We'll talk a little bit about the crosswalk between the essential health benefits in exchange plans and in the benchmark plans or alternative plans in Medicaid. And then I will follow up with a little bit of a conversation about benefit coverage for persons with mental health and substance use disorders. One of those benefits that, as Sonia mentioned, may be one of the more transformational benefits that exist right now in that 10 categories of packages. So with that, I'd like to turn it over to Susan.
Thank you. The Affordable Care Act assigns the responsibility for setting up the multi-state plan programs. And we believe that Congress did this because of our 50 years of experience of providing health insurance and sort of an exchange like that to federal employees. So I'm going to talk very briefly about what the program is, and then particularly from this panel about essential health benefits, how we developed and our thoughts on how implementing an essential health benefit options in a multi-state program context. So OPM has been directed under Section 1334 of the Affordable Care Act to enter into contracts with private health insurance issuers to provide at least 2 multi-state plans, and at least one has to be from a nonprofit entity. And an entity is not an issuer, so we also sort of had issues about defining what that is. In the first year of participation in the program, an issuer has to have plans in 31 jurisdictions, and by the end of their fourth year of participation in the program, they have to have plans in all 50 states and the District of Columbia. If an issuer enters into a contract with OPM successfully to provide a multi-state plan, those plans are certified to be offered in the state marketplaces for which there is a contract. And so they don't have to be certified or applied to the states. We are taking the approach, just generally speaking, that in terms of going for form filing and rate filing, that the state level plans would go through the state insurance commissioners. And so obviously there are challenges in making sure those processes sync up by the time that we have to finish contracting with plans to get the information to CISIO so that the benefit and rate information about our plans can be listed on the websites. So just one thing to add to what Sonia is saying, while October 1st is the display shopping date, the real date for all these plan negotiations from a timeline standpoint that have to be completed is somewhere late summer, because at least the last time I heard, and I commit not to have checked this, initially CISIO was still going to have the 30-day shopping period starting September 1st for people who shop before they could buy. And then they're going to have a test period if they're supposed to have a test period to make sure all the data flows. So the 364 days is actually is for people who are for exchanges and us who are contracting with plans kind of 2 months shorter than that, at least. So it's just sort of a timeline things. So to give a very non-legal analysis, an analogy of how what a multi-state plan fits into an exchange, if you would think of the healthcare marketplaces as sort of like a health insurance grocery store where consumers can shop for plans, once the stores are built, or the exchanges, how do the shelves get stocked? And so if you think of what a plan is, say, a brand of health insurance, insurers want to come in because they know hopefully there'll be lots of new customers coming in. And so they can get their cereal or their plans on the shelves in 2 ways. They can either negotiate directly with the exchange, or as I said, they can come and see with us and kind of have one-stop shopping to get their plans on the exchanges. The approach we're taking is we're not mandating what states issuers go into in the first year. So we could have one issuer in 31 states and some overlap, but it won't necessarily be identical. So right now we're working with potential issuers to get our plans on the marketplaces, and I went through the timeline issues. So in terms of how we're handling the essential health benefits issue, when we first started 2 years ago looking at what approach to take. The other provision of the law is that it tells us that we're supposed to administer the contracting process of the multi-state plan, similar to how we do it in the Federal Health Employees Benefits Program, which there was their national plan, and then, you know, say Blue Cross Blue Shield, GIHA, and similar kind of nationwide plans, and then there are local HMOs. And so I think internally a lot of folks felt, you know, this was supposed to be like GIHA or Blue Cross, where there was a standard plan. And so as we put out an RFI, we did market research, we asked issuers lots of questions about what would enable them to come in and offer these plans. And some wanted to do the state benchmarks quite strongly, and some wanted to do a more uniform package so that they, you know, because they were just starting up in this market, and it would be easier for them to, you know, basically build their plan and their networks that way. So this is the approach that we kind of came up with, sort of a compromise approach. The MSP issuer can either offer a benefits package that reflects each state benchmark. So one option is you go with what the state's benchmark is. The other option is to pick one of 3 OPM selected EHP benchmarks, and those are the top 3 federal plans by enrollment, which were included in the EHB guidance that first came out. An issuer would have to pick this uniformly, like you couldn't say decide to do state benchmark in 25 states and the national benchmark in 26. In either case, the benefits package has to include any state-required benchmarks enacted before December 31st, 2011, which is consistent with the EHB rule. Our issuers will also have to follow state laws regarding benefit design flexibility. So in states where there's going over standardized benefit packages, an MSP issuer cannot offer the national benchmark. So in those, and right now we only know 4: California, Connecticut, Oregon, and Vermont. So if you were an issuer who picked one of the FEHB plans, in those 4 states you'd still have to comply with the state defined benefit package. And we had a proposed rule, and our final rule is going on display at the Federal Register in about an hour and a half this morning. So we're very happy about that. And what some of the comments that we got was that by having a national, FEHB benchmark, that it might cause adverse selection or unintended consequences. And we looked at that really carefully, and as did ASPE when they were doing a lot of their EHP research, and basically what was found was that the differences between the OPM benchmarks and the state selected benchmarks are not likely to be very actuarially different in a significant way. And the scope of our benefits are generally similar in scope to those covered by the small group market plans that were covered by the states. So we're not really aware of any compelling evidence right now that would suggest that there would be adverse selection, but this is something we certainly, as the administration goes on, will pay attention to. And so for all of this to work, we're going to be working very closely with states. We're going to work with them, as partners. We've been working very hard to cultivate relationships with state officials. We're going to continue to do that. We've been, talking with NIC, meeting with commissioners. Where there are issues of conflict, we're going to work to create memorandum of understanding with states, and that's a task to come forward. And also, there is an issue, we also have this level playing field provision that says for 13 categories of law, if an MSP or a co-op doesn't comply with that law, that no one else issuer in the state has to do that either. So our general approach is that MSPs will have to comply with state laws, and we're going to set up a process yet to be developed that, if a state has a disagreement with us, they can come in and we can kind of try to resolve the difference over this process rather than resorting to litigation in the first stage. So that's a general summary of our approach with respect to essential health benefits.
I have slides too as well.
Does anybody have a question while Maddie's setting hers up?
The multi-state plans that you're talking about, are you assuring that there will be a new plan offered in every state? I guess what I'm wondering in it is if issuer X is a successful bidder with you and they already offer plans in New Jersey, will there be an additional offering, or will that just overlap with what we already have?
There's a product that's going to be the multi-state plan, so it'll be a different offering in the sense that it's offered under contract with us. Now, whether it's extremely similar to something else that's offered, either through the state exchange or outside the exchange, that's kind of out of our wheelhouse. But we'll be certifying multi-state plans.
Okay, thanks.
Patty, do you want to give Wally and then we'll...
Sure, yeah, happy to. Thank you for inviting me to be here today. I'm Patty Buzang, and I'm with Manat Health Solutions. And Manat is a law firm, and Manat Health Solutions is a strategy and consulting group that's part of the law firm, and we have attorneys and other professionals that are working with states on healthcare reform implementation, both in state exchanges, federally facilitated exchanges, but also in Medicaid. And I think Sonia gave us a great picture of the really heavy lift, all the work that states have to do to be ready for healthcare reform. So I'm going to talk today a little bit about the crosswalk between essential health benefits and essential health benefits in Medicaid. So essential health benefits in the private market and the work that states are doing to implement essential health benefits in their Medicaid programs, particularly for new adults. And my first slide, those of you who have worked in Medicaid for a long time like I have will get, which is what benchmark are we talking about? Well, we Medicaid wonks thought we owned the term benchmark. I mean, benchmark is Section 1937. It's the benchmark benefit option that states have for their Medicaid programs. But when the ACA was implemented and CISIO started to give pre-regulatory guidance about essential health benefits, they co-opted the term. They stole the term benchmark benefits. So we had to come up with a different way to talk about the essential health benefits for newly eligibles in state Medicaid expansions that were authorized under the ACA, that were mandated under the ACA. And so the new term, which we learned with the January draft guidance on Medicaid benefits, is alternative benefit plan. So we're talking today really about the alternative benefit plan, but benchmark is still a really important term because it still applies when we're talking about essential health benefits, which again are the comprehensive benefits that states have to make sure that their private markets, both inside and outside of the exchange, that insurers, issuers are providing through their health insurance plans. The base benchmark plan is the starting point. This is what the states have been doing over the last 12 to 18 months to develop their EHB, picking a base benchmark plan, and then looking at that against the categories of essential health benefits and supplementing it as necessary to come up with their state EHB benchmark plan. And we're going to talk a little bit more about that because it really has relevance for what states have to do in Medicaid. So just to do a little level setting, I think you all know this, but the ABP is relevant. It is the benefit package that states have to apply or provide to their new adult eligibility group. The newly eligibles, of course, are the non-disabled, non-elderly folks with incomes up to 138. So wherever a state's Medicaid income eligibility level is now, up to 138. Really the parents, childless adults, caretakers in that category are your newly eligibles. That's the group that has to get the ABP. There are some exceptions, and I'll talk a little bit about what those are. And that's the group for whom states are going to receive the enhanced FMAP, the 100% for 3 years, ratcheting down to 90% in the out years. So that's who we're talking about when we're talking about the ABP. So what are the basic requirements for the ABP? Well, as I said, includes all 10 of the essential health benefits, and the definition, the way the state has to figure that out is by looking at an EHB-based benchmark plan, and I'll talk a little bit more about that in a minute. I think the other important thing to note about the ABPs is that
they have to be given to the new adult eligible group, but to the extent you're a state that has a benchmark plan already in your Medicaid program, you've got to align that existing benchmark to the new ABP requirements as well. Not a lot of states actually took advantage of or implemented those benchmark benefit programs, but there are a few out there, and so part of their work, if they're an expansion state, is looking at the ABP for their newly eligibles, but also for some of their current eligibles as well. Ellen is going to talk more about the second requirement here, which is that the ABP has to meet the Mental Health Parity and Addiction Equity Act. This is a new requirement in the ACA. It's not a requirement that applies now in Medicaid fee-for-service. Excuse me. And so this really means that states sort of have a two-level screen on benefits for mental health and substance abuse. One, to make sure that they're in the ABP, but then really to apply that parity screen as well. EPSDT, again, a requirement that's very familiar to those of us in Medicaid. Non-emergency medical transportation, these are also benefits that have to be in the ABP. And then prescription drugs, and there are other Medicaid-specific requirements around benefits that are going to apply to the ABP. I think cost sharing is another one that's worth mentioning because it's really in the wind and on the minds of a lot of these states who are thinking about expansion. How much can we do on cost sharing? Well, in the ABP, you really have to meet the federal cost sharing requirements. There is some new flexibility for states that came out in the most recent regs, but you can't go beyond, for this new adult population, what you can do in Medicaid generally. So this slide I just am going to put up quickly because this really is these base benchmark options that states worked with to define their essential benefit for their private market is relevant. It is also part of the calculus for determining the ABP, so I really wanted to have this as a reference for us. Okay, I acknowledge that this is an awful slide. It's horrible. So I won't totally torture you with it, but I do want to talk to you a little bit about the process that states have gone through or are going through now in terms of defining their alternative benefit. There really is a sequence that they have to go through. And the first step in that sequence is to look at the 1937 options, and there are 4. 3 of those options are commercial health plan options in the state, and within those options, some of those commercial options are also the EHB benchmark options. Not all of them, but some of them. So if a state chooses, for instance, the largest non-Medicaid commercial HMO as the starting point for their alternative benefit plan, and it is also one of the EHB-based benchmark options. Really, they just have to go through the process of saying, do I need to supplement anywhere here? And if I do, I supplement, and then I have my ABP. That would be the most straightforward path here. It is not the path that most states are taking for a couple of reasons. Most states are really have the starting point for their ABP as that secretary-approved plan, that fourth option that you can come up with an ABP that receives secretary approval. And there are 2 main reasons that states are ending up in that bucket. One is that they want to use their standard Medicaid benefit as their starting point. It might not be their ending point, but it's their context, and it's kind of where they want to start. And I think, as Sonia said, I think a lot of states started out or thinking about, oh, heck, let me just make it one benefit package. And there are alignment considerations there, too. It's complicated for states to start setting up tiered benefits within their Medicaid, complicated from a systems perspective and a benefits design perspective. So that's one reason why it's been a starting point. Another reason is that as soon as a state looks at another starting point and says, yeah, this kind of works for me, but actually I really want to add these 1 or 2 additional benefits, it automatically puts them in the secretary-approved bucket. So that's where we see most states ending up. So, assuming for our discussion that we're in that 4th bucket and that a state is using its standard Medicaid benefit as a starting point, they have another step in the sequence, which is they then have to go to those 10 base benchmark options that the state also looked at for its EHB in the private market and pick a base benchmark. Many states that we're working with are picking the same base benchmark they picked for the private and individual market, the individual and small group markets. Makes sense. They've just spent a lot of time really understanding why that was the right decision for their state. So They supplement that, so they come up with an EHB benchmark, and then they have to do a comparison of their standard Medicaid benefit to that EHB benchmark product or that EHB benchmark benefit. And when they do that, they have to make sure there is alignment. And I think an important implication for states and an emerging implication for states is that that EHB benchmark is a floor, that the state could look at their standard Medicaid benefit against their EHB benefit, and if they want to do more that's in that benefit, they absolutely can. But if there are places, benefits where that EHB base exceeds what they're doing in current Medicaid, they've got to bring up the current Medicaid benefit to become their ABP. And that includes in scope, duration, and amount of benefits. So, for example, mental health services, which I know Ellen is going to talk a little bit more about, it could be that that EHB benchmark that they're looking at, that they've supplemented, has fewer mental health visits than they offer today in their current Medicaid. And so they say, you know what, we want to stick with what we do today, or we want to do more. We've really looked at this and decided we want to invest in providing a robust mental health benefit. We've worked with states where, in fact, that EHB benchmark had a higher amount of visits in mental health than their current Medicaid. So they've got to bring that Medicaid level up to be their ABP, to sort of meet the EHB requirement. There are also a couple of services, frankly, that states are looking at that are in the EHB benchmark. Inpatient services, for instance, in many of these plans they're looking at, those 10 options include transplant services. And if that is true of the state's EHB benchmark, they've got to provide transplant services in their alternative benefit plan, in their Medicaid program. And a lot of state Medicaid programs don't cover transplant today. IVF is another example. IVF appears often, especially because some states mandate it as a benefit. And so Medicaid programs are looking at an ABP that will cover IVF services, theoretically. So really interesting implications. I think when we started down this road of thinking about the alternative benefit plan and Medicaid, folks were thinking, well, that'll probably be a skinny down benefit from what we provide in Medicaid today. I think, you know, states that were really trying to think about integration and alignment were thinking, well, our real challenge will be aligning to the QHP benefit, you know, aligning to the EHB we're providing in the rest of the market. And states have a real interest in thinking about, now that we have low-income people who are going to be subsidized in our private insurance market, you know, where are the places to create alignment, and benefits is one of those opportunities. And what we're finding is that the EHB is kind of a great equalizer, that it really is pushing both Medicaid benefits and private market benefits to be more aligned than I think we initially thought they would be. So I said earlier, and I wanted to point out, I think another really important emerging issue or understanding that states have grasped with respect to their alternative benefit program relates to individuals who are exempt from mandatory ABP enrollment. This is the list of exempt folks, and this doesn't mean they're excluded from being in the alternative benefit plan, but it means you have to give them the option to go to a standard Medicaid benefit if that's what they want and that's what they need. I think medically frail individuals is the population that's most complicated here. First of all, the definition is broad, and I think will be interpreted by states potentially differently. But I think what's very important, and what we didn't understand initially, is that states receive the enhanced FMAP for newly eligible adults regardless of whether they have the ABP, or for folks who exempt out, those folks exempt out. In other words, I didn't say that well at all. Basically, if you're a newly eligible adult, the law says those folks have to get the ABP. But there are some people who are going to exempt from that. And with respect to the enhanced FMAP, the money really follows the person. That if you're newly eligible and you're exempt and you go to the current Medicaid benefit, the state still gets the enhanced FMAP. And I think that early on, we were thinking, well, we really have to make sure that we keep people in the alternative benefit program, so maybe we need to make that really robust so people aren't defaulting out to current. But the truth is, for these exempt individuals, the states are still going to get the enhanced FMAP. And I think that's been a really important piece of information to inform how they develop their benefit programs. There are differences between the Medicaid-driven differences between the EHB and the ABP, and I've listed them here. Because the ABP has to cover EPSDT services, that comes with pediatric oral and vision services that exceed what would be provided in the EHB. And so to the extent that base EHB plan doesn't include those services, Medicaid has to do more. Habilitative services is really interesting in the draft regulations. This is a place where CMS has really asked for states to comment that they didn't go ahead and define it as it was defined for the EHB. They gave some options as to how states can define it, so we really could end up in a place where habilitative services is being defined differently. And prescription drugs is interesting too, that there's a floor definition for the EHB that isn't going to apply to Medicaid, and this is actually an area that we're doing a lot of work in now to understand what that really means and how it really will be implemented in the ABP. So there will be these differences, but in general, we're seeing a lot of alignment across EHB and ABP, and really seeing that the EHB definition and requirement in the law is driving how states are thinking about their alternative benefit for their newly eligible Medicaid beneficiaries as well. So thank you.
And so just to round out the conversation just a little bit before we start asking more questions and answering those questions, I wanted to talk just a little bit about the coverage of individuals with mental health and substance use disorders under the Affordable Care Act. And as Sonia said, there are some of these benefits that may in fact be more transformational in the way our healthcare services have been delivered. And I think the community of folks who have been working with mental health and substance use disorders really view this benefit as in fact one of those. Although many states right now may have some mandates in their own state law for the coverage of these disorders, it varies dramatically. There are often extreme limits on the duration of care. The cost sharing is very different. Oftentimes there's medical management standards that really make these benefits not very available. And as a result of that, I think we all see the effects of that inadequate coverage for persons with mental health and substance use disorders on our healthcare system. And I think what folks are hoping that now with the recognition that these are benefits that are really in fact essential health benefits, that it will start changing the delivery system in many ways, that in fact you will have earlier diagnosis of these problems in primary health care settings, that you will be developing more comprehensive and robust networks of providers to provide care both in the private insurance and the public insurance market, that in fact there will be more referrals to services, and that in fact cost shifting will end in some ways. Cost will not be shifted to individuals to cover the cost of their care, and it won't be, and the cost that should really be covered in the private insurance market won't be shifted to the public insurance market. So that's one of the things that we're really looking forward to, and I think as Dr. Sharfstein said, this is probably one of those benefits that folks said, we want this fixed now, and we want it fixed right, and we want it implemented today. And I think probably we will also begin to see this happening over the course of time. One of the important points that Patty raised is that not only are alcohol and drug benefits and mental health benefits included in the essential health benefit package, but in order, the final regulations have indicated, and there's been guidance from HHS over the past year that indicated they were going in this way, but in order to be actually providing essential health benefits, those benefits must be provided in compliance with the Federal Mental Health Parity and Addiction Equity Act. Now, for those of you who are not familiar with that act, let me just give you a very brief background, because this really is the story of how the Affordable Care Act and the Parity Act worked in tandem to create a comprehensive set of benefits. What the Parity Act does is that it prohibits carriers from, and plans from providing either separate or more restrictive quantitative treatment limitations, duration of care, scope of services, quantitative treatment limitations or cost sharing requirements, financial requirements, more restrictive services and standards for mental health substance use disorder benefits, and the medical surgical benefits. So it is a comparison of our cost sharing requirements, durational limitations, are those comparable across mental health substance use disorder benefits and medical surgical benefits. But in addition to that, there are treatment limitations. The treatment limitation language has been defined to include not only these quantifiable limitations on duration of care, but also non-quantifiable limitations, which cover virtually every aspect of a carrier's plan. It includes the medical management standards. It includes network adequacy standards. It includes the cost that is of reimbursement for providers. It includes things like fail first policies. So just almost every single aspect of a health benefit package is now regulated under these Parity Act standards, and those plans must provide comparable services. So some of the discriminatory standards that have been baked into insurance plans historically should start disappearing under both the requirement that these benefits be offered as well as these Parity Act standards. Now, in Maryland, what we did was we took advantage of that parity standard to really get in place at a very threshold level a comprehensive benefit for mental health and substance use disorder services. One of the issues that is still unclear under the parity regulations, because we've been operating under an interim final rule since July of 2010, one of the issues is whether parity actually covers the scope of benefits. And again, we think there are very good legal arguments to support that. But in Maryland, that was the position that mental health and substance use disorder advocates took, that there was no question that this covered scope of benefits. And therefore, the scope of benefits that was to be provided for mental health or substance use disorder should be comparable to that scope of benefits that's applied for medical benefits. And in that way, that process, working very closely with state officials who were very, very supportive of a very comprehensive benefit, we were able to ensure that when the final decision was made as to what Maryland's essential health benefit was going to be, the state decided to not use the small group benefit, which was what our benchmark was going to be, but to instead substitute in the federal GEHA plan benefit, which in fact was the most comprehensive of all the 10 benchmark plans that were out there and available. So that's where we've started with the threshold benefit. What we also thought that the Parity Act did was provide us with some real backstop when the conversations arose as to whether or not the plan was balanced and non-discriminatory, because there may not be a lot of definition to those terms for other benefits within the essential health benefit package, but the Parity Act really does define what constitutes discrimination, and therefore we were able to use that again in asserting those types of standards. We think the Parity Act also would have been helpful if there were conversations in our states about how you begin to substitute benefits within any particular category of the essential health benefit plan. Again, Maryland made a decision that for the first 2 years there would not be any benefit substitution even within categories, but looking to other states where you have that situation, you may be able to use that as well to prevent some of the movement within benefits. As I said, the state took a very proactive approach on this. I took a very quick look at some of the other state plans that have now been posted on SSIO's website to see whether other states were doing the same thing. Were they using the Parity Act in a way to really develop a robust benefit and to eliminate some of those historically discriminatory standards? And I can say that from the information that I saw, it was clear that, again, there wasn't a lot of detail with regard to some states, so it wasn't clear exactly how comprehensive their benefit would be. But interestingly, you did still see some of those restrictions on duration of care in certain states that have historically been existed. So limitations on inpatient care of 30 days per year. Restrictions even on outpatient visits of 20 or 30 visits per year. Items and features you would think would be now eliminated if there was a comprehensive implementation of the Parity Act. We also saw some plans that have explicitly excluded certain benefits. So residential treatment services and in a non-hospital residential care. Again, some states have explicitly excluded that care. Question exists as to whether the Parity Act will permit that or not. But there have been other services that are excluded, such as methadone maintenance treatment for the coverage of opiate dependence. Again, something that's integrated into many public health systems, but is going to be excluded in some states in their qualified health plans. We also saw some of these standards that are these non-quantifiable treatment limitations, these pre-authorization standards that, again, are regulated under the Parity Act. We see some of those standards still slipping in. So Arkansas, while it has also adopted the GEHA benefit, which is a very comprehensive benefit, has also stated that all benefits for mental health and substance use disorders must be pre-authorized before they're going to be delivered. Again, not an equal standard in the medical context. So again, it raises this Parity Act question. And again, some other issues such as a patient's care won't be covered if they leave treatment against the orders of physicians. Again, a standard that's not applied in the medical context, but again, so raises parity issues to the extent it's applied to mental health or substance use disorder benefits. So I guess the only question that remains is as we will see over time how the benefits do get implemented, we'll begin to take a look at whether or not more adequate coverage of addiction and mental health services actually begin to reduce costs, particularly where you see some very costly services of higher rates of hospital admissions, higher rates of ED department use among this population. If we begin to see a more comprehensive community-based system of care, we may be able to see those costs coming down. Thank you. So with that, we can open it up then for further conversations about the issues that Susan, Patty, or I have raised.
Maybe I could offer something. Kevin Lusher from the Health Policy Institute at Georgetown University, and we're actually going to be coming out with a paper, one of these state action papers on where states landed and how they made that decision on their benchmark plan. And it'll be coming out through the Commonwealth Fund probably in the next couple of weeks. So, Sonia, we can add it to your presentation. I would say, first of all, this was not an easy task at the state level for states, and actually only about half the states formally picked their benchmark plan. Many struggled with it, and about half defaulted to the small group option. And on top of that, I think that what we heard from states is there's just lots of lingering questions. How are they going to deal with substitutions? How are they going to figure out if the benefit design is discriminatory or not? There's a whole slew of them. So it'll be interesting to kind of see, now that we have the benchmark plans, what happens during full implementation. And then I think what is often lost in this conversation, and you might have covered it, Patty, but I had to step out, is that really the essential health benefits package only applies to the individual and small group market. So it doesn't extend to the large group market or the self-funded market. So, we have to be cautious about, how this may affect kind of long-term outcome when it applies to such a small segment of the insured market. So I just offer those comments.
Roger Schwartz with the National Association of Community Health Centers. I think this is probably more going to be a conversation for this afternoon when you're talking more about Medicaid expansion, but I thought since Patricia had talked about the alternative benefit plan, it was worth at least raising the point that in Section 1937, the provisions that talk about benchmark benefits and all that stuff, there actually is a provision further on down that was in the law prior to the Affordable Care Act that says something like, notwithstanding any other of these provisions in the prior sections, the extent that that patients are getting services at federally qualified health centers, they remain entitled to the services, the Medicaid services that those health centers provide, and the health centers are supposed to be paid as they're paid under the Medicaid statute. So we actually commented fairly fully on in the comments that were due last week, because there was a notable absence of any discussion of that point at all in the proposed rules. our understanding from CMS is that they don't disagree that there's this provision, and in fact it does apply for this new population of eligibles. And I think the response is, well, it's already in the statute. We've already covered it in the regulations as they existed already. And therefore, there's no need to cover it now. I think maybe the answer, or one of the answers why we have not heard so much from it, is what you said. If most of the states are going with a secretarial approved plan, and if that plan basically covers the Medicaid services as we know them in most cases, maybe the assumption is that those FQHC services are going to be the same services in the approved plan anyway, so there's nothing to talk about other than the payment, which is a big deal for the health centers, but isn't necessarily something that would be discussed.
I think that's right. I didn't mean to categorize FQHCs or FCs and other, but I do think about it as, you know, EPSDT, non-emergency medical transportation, and those requirements around FQHCs.
And it's funny you say that, because in our comments we said, we suggest that you sort of package us with EPSDT, et cetera, et cetera, et cetera, because we thought that notion made a lot of sense.
Yes, I think, I don't know if this is a question for Ellen or Patty, but I'm trying to get my head around one of the things that we've been arguing as we've traveled around the states trying to get them to adopt the Medicaid expansion is really around the mental health substance use disorder benefit and the fact that states spend a lot of money on that now for uninsured people who would become eligible. So I just want to make sure I'm getting this right. So, and this is sort of the irony, they're really, the parity requirements would not necessarily apply to the traditional Medicaid population today, right? I mean, particularly in fee-for-service.
Not fee-for-service, but for any state that already provides services to Medicaid managed care organizations, parity law actually does apply. And in 2014, it now will apply regardless of what mechanism through which those services are delivered.
But if somebody sort of opts out because they're medically frail, which is going to be a lot of those folks, and it's in a state with fee-for-service, it's sort of ironic, right? Because they're going to end up without that protection.
It is, and I think that's one of the perfect examples of where this has kind of been turned on its head a little bit, where we were working in a state where in fact they have really poor, it's a fee-for-service state, poor mental health coverage, no substance abuse coverage, and in their traditional Medicaid benefit, and they're going to have parity in their ADP, and so that's exactly the question we came up with, which was, okay, so what if you're medically frail and you need some of what's in the traditional benefit, but you really need those mental health and substance abuse, you know, what's the choice for that beneficiary? What's the right option for that beneficiary? So, you know, I should also say that, you know, maybe this is a place where another state flexibility is to create multiple alternative benefit packages, and so, you know, maybe there's an alternative benefit that's targeted to that population where you are bringing in some of those situation services that aren't going to be available to your entire newly eligible group.
And you can opt into it even if you're exempt, which of course complicates the whole thing. But I think that's sort of where I landed, is that you have to be really creative around this and use that flexibility.
Yes, I don't think it's all as sort of linear as we all first thought it was when we were thinking about this, and even for states, and I know a lot of them, and maybe this works if you're a state that has a robust current benefit, but that are saying we're just going to go with our traditional benefit, there are still issues they have to grapple with, I think.
I mean, and the only other option, I think, is, I mean, there are new sort of medical homes that some of the states are also thinking about developing, and they may, and Maryland is looking into that, and maybe some states will start developing that with regard to other individuals with very complex co-occurring chronic conditions, including mental health and substance use disorders.
Yeah, Leonardo Cuello with the National Health Law Program. We're certainly thinking a lot about the benefits. And this question, you know, has been sort of out there from the very beginning of which package do we think is going to be better. And I think one of the things we're learning is that it's going to be state specific, right? That it's going to depend a lot on what the state does in its traditional benefits package. And you would think states that do a good job in their traditional package probably are the ones that are kind of correlated to likely do a good job with the ABP, but you don't really know. And I think the other thing that really complexifies it is that it's also going to be individual specific, right? So you could really envision a scenario where overall maybe the traditional Medicaid benefits package is better for 90% of the people, but there is some feature in an ABP, right? Maybe it has a targeted benefit around some kind of additional habilitative services, maybe it has better mental health services, that makes it the better choice for certain specific people. So I think that that's a complexity. You layer in the complexity that Judy mentioned about the fact that they can offer this to people on a voluntary basis who are exempt, right? So people who are voluntarily exempt can be given the choice to come into this. And I'm pretty sure that one state has actually done that choice through a passive enrollment scheme, right? Which is the way a lot of enrollment world, that seems to equal enrollment nowadays. So I think that creates a whole other question of whether the state might have an incentive to do that in a lot of cases, and whether that might be good for some people and bad for other people. And then, the last thing that I just don't know how to deal with at all is we talk about the structure of, well, okay, if you apply and you meet one of these exempt categories, then you're exempted and you go to the traditional Medicaid benefit. How the heck do you identify these individuals, right? Because at the point of application, they may be using a streamlined application that isn't going to collect the information you would need to make an assessment of medical frailty. And then they're just in the system, sitting there, and when does somebody in the state look at their file and say, wow, Mrs. Jones has had 7 hospitalizations in the last year and has 4 serious conditions that she's dealing with, and she seems really pretty medically complex, we're going to give her an exemption. Yeah, how that happens, and there are states that have done interesting things around looking at claims data and using that to trigger identification of people who look like, wow, this person's very involved based on their claims data, but how that happens. So whatever we think the best answer is, I don't even know how we get the person to that place.
I think that's a great point, and I think that you're right that the single streamlined application is only going to be designed to identify people who might be non-MAGI, right? People who might be eligible for a different kind of age-blind or disabled eligibility determination. I do think states are grappling with what is medically frail, how do we define it, and how do we figure it out? And I think they have, there are a lot of incentives for them to do that well, and I think you've mentioned some of the ways they're thinking about it, including looking at historical claims data, easier in some states than others.
Sydney, did you have one final question or thought?
I have a comment and a question. Do I need to choose between the two?
We're getting close to our time. We're going to have lots of time in the afternoon also to talk about Medicaid benefits. So however you want to do it.
So very shortly, my comment, I'm Sydney Watson. I'm from St. Louis University in Missouri, and we're working on first order questions. And very concerning to us was that when the state did actuarial estimates on the cost of Medicaid expansion, their assumptions were that the alternative benefit package would cost less than the traditional benefit package, and that's just the assumptions that get talked about. It has nothing to do with anyone figuring out the plan. My question's for Susan. I sit on the Rural Research Institute Rural Health Panel, and we've been very interested in the MSPs because our concern about the exchanges is, they're built on the idea of competition. Competition in rural areas is simply mythical. And we've been following the federal employees plans, looking to see how that affects competition in rural areas. And our research over almost a decade now is that there's very little competition in rural areas. It's really Blue Cross Blue Shield. So a couple of questions we were interested in was, in the states in which there will be MSPs offered, are you going to require that plans be offered in all geographic areas?
Not initially, because our challenge is to get two issuers to be ready to up an offer in 31 states. Our goal is for them to get statewide and be in all geographic areas, but our goal is to get folks in and help them grow. And I think if that was the case, we could.
And I think our comment on the proposed rules follows that. Our concerns that if you can leverage to get some of these offerings in rural areas, it could help, but also understanding that getting the offerings is going to be a challenge.
Yeah, it definitely is.
Thank you.
Can I ask one question, Susan? Can you comment a little bit on the feedback you've had from states on and their concerns, on the multi-state plans?
Well, I think, we've had, most of the comments I think we got were, and more, and, I'm looking at this not necessarily from the formal comments, but just sort of the dialogue. How are we going to work in rating? How are we going to work, in form filing? What's the appropriate relationship? So, those are sort of the main areas of focus, who has the final decision. So I think we generally come out to say that multi-state plan issuers are going to have to follow state law rules. And then, as I said, we're going to require them to follow the first year this is going to be tricky from a timing standpoint, because our process, kind of like the link with that, the coordination with guidance and state laws, our application process and timing is very different than the state, is behind the state processes for the first year. So those are sort of the big issues. And so, we're going to have to work through a lot of things with states, and we're building up our capacity to do that.
Great, thank you. Why don't we take about a 15-minute break, and we will start again at about 10:45.
Thank you.